Hello, everyone, and thank you so much for joining. My name is Kristen Wall, and I'm an assistant professor of epidemiology at Emory University. Today, I'm very excited to be presenting data from a DFID-funded study, the goal of which was to develop and validate an algorithm to screen for female genital schistosomiasis in Zambia. Neither I nor my collaborators have any conflicts of interest. So by way of very brief background about the study rationale, unfortunately, there are no routine screening or diagnostic efforts currently taking place for FGS in Zambia, which is similar to many countries in sub-Saharan Africa. Identification of FGS is difficult due to confusion with symptoms of other genital abnormalities, and routine diagnosis with colposcopy, which is the gold standard, is not feasible or affordable in most government health facilities. So our study objective was to build a screening algorithm for FGS in adults in Zambia that is feasible for use in government clinics. Our data are coming from a standing longitudinal cohort of women at high risk for HIV in Lusaka and Ndola, Zambia. We enrolled 497 study participants between March of 2020 and December of 2021. This cohort is comprised of adults who are HIV negative, female sex workers, or single mothers. The HIV incidence and the prevalence of other STIs are very high in this cohort. So here I'm showing that among the 497 women who were enrolled, the prevalence of FGS was 23.5%. The distribution of FGS indicators is shown in this table, with the most common indicator found on colposcopy being abnormal blood vessels and homogeneous yellow sandy patches. And here's the final algorithm, with this table also showing the adjusted odds ratios from a logistic regression model, as well as the weighted risk scores in the final screening algorithm. These indicators can essentially be used as a checklist during screening, and I've broken them out here so you can see that there are various environmental, demographic, and gynecological exposures. The goodness of fit test indicated good model calibration, and the risk algorithm had reasonable discrimination as indicated by the area under the curve. Here I'm showing the screening algorithm performance when using a cutoff score of greater than or equal to 2 or greater than or equal to 3. So using a score cutoff of 2, the risk algorithm had 70% sensitivity, 56% specificity, 33% positive predictive value, and 86% negative predictive value. So just a quick note on the positive and negative predictive values. While the sensitivity and specificity are characteristics of the tool, the PPV and NPV are highly related to the prevalence of the outcome in the population. And our positive predictive value was consistently fairly low. And this highlights that the screening tool should not be used or considered as a diagnostic tool in this population, but could certainly be used to increase what we call the pre-test probability of a disease, or the prevalence of disease in the population that is referred for onward diagnostic testing. In conclusion, we found that FGS prevalence in adult women living in urban areas of Zambia is concerningly high. Ours is one of the first studies to develop a simple screening algorithm to improve diagnosis and treatment of FGS in adults. This is a simple screening algorithm comprised of measures that could be gleaned from a checklist. It could be a cost-effective screening tool for referral for diagnosis. Just as a reminder, there are currently no screening tools in use in Zambia. It's also notable that this high FGS prevalence was observed in a high HIV risk population. And as others have noted, a proportion of HIV infections might be prevented by identification and treatment of FGS. And I would like to conclude by acknowledging and thanking my collaborators, the study participants, and study staff. And of course, I would like to thank the Task Force for Global Health and DFID for their support of this work. Thank you.